So I think after lunch, you need to take a nap, right? But I try to motivate you to listen to my talk. So first, I would like to thank the organizing committee, Dr. Saad, Dr. Nadeem, Mistro for the invitation. Thank you. It's a pleasure to be here. So my talk will be on CBCT-based online adaptive radiotherapy using the ETHOS system, how we're using this system to optimize the patient care. Enter is, okay. Though I have no actual or potential conflict of interest in relation to this talk, I'm a co-PI in a Varian-funded research project. The outline of my talk, I will start with a brief introduction of adaptive radiotherapy, and then using how ETHOS is a suitable ART system. What's our experience with ETHOS? Then I switched the gear to talking about a surface-guided radiotherapy and how it's used on the ETHOS system. What are our current challenges with ETHOS? And I will conclude with a brief summary. Dr. Mohammad Riyas, yesterday on his general session talk, he shared with you who we are. So the Radiation Oncology Department is within the National Center for Cancer Care and Research. It's a premier cancer hospital within the state of Qatar. Actually, it's the only center within the state. It provides state-of-the-art cancer radiation treatments for a variety of tumor types, pediatric all the way to adults. We treat about 1,000 cases annually. As all other centers within the region, around 30% of our workload is breast cancer. If we look at some stats, we see that the number of patients doubled since 2016 to 2022. And this is mainly to definitely the increase of population within the state. Multidisciplinary teams, we have around 20 multidisciplinary teams, more awareness of cancer, engagement of primary health center, all under the umbrella of the National Cancer Strategy. If we look at site-specific, breast will contribute to the highest, followed by bone, pelvis, head and neck, and others. Rapid arc is a main technique, so we do advanced technique, followed by field and field because we have a lot of breast cases, parallel opposed, 3D conformers, and 3D conformal and others. When it comes to the technology, we have a big spectrum from simulation, treatment planning, Eclipse research, imaging processing softwares, and data extractions inside of. And when it comes to the delivery systems, currently we are installing the TrueBeam on one of the bunkers. We have the IX and the other one. We got exact track on one of the linear accelerators. SGRT, Align RT from Vision RT is available on all of them. CyberKnife M6 and brachytherapy, active brachytherapy program. And last but not least, the ETHOS system. So image-guided is a standard imaging modality that we're using for all our cancer patients, and it uses simply medical imaging system to help provide precise and accurate radiation treatments. However, we're facing challenges with this current technology, especially when we're looking at intrafractional changes. Anatomy changes pose a hard challenges to our daily treatments. Soft tissue deformation, setup difficulties sometimes, tumor growth and shrinkage. Sometimes even in the bladder, for example, if we take a prostate cancer treatment, there will be an inconsistent bladder and rectal fillings. We have a program for that, we have a prep for the patient, but still we're seeing some problems and discomfort for the patients when it comes to these issues. Also, if we look at the dosimetric impact, sometimes the bowel loop might come into the high region, and this is also will be a limitation. So, if we look at the literatures, a lot of literature shared this data that we're seeing changes in the ITV, for example, in the GTV volume between the initial simulation and after treatment. This is an example what we've seen in the changes in the GTV after 4 weeks of RT. What does this have to do with a dosimetry? Well, we're seeing a dosimetric impact on these volume changes. We're seeing overdosing of the organ at risk, underdosing sometimes of the target. So we need a solution, and might be adaptive. Adaptive approach is aiming to get the target every day. How can we do that? There are two types of adaptive radiotherapy. I think previous talks mentioned this. So the offline and the online. I think the tomotherapy, they shared with us their offline platform. So how we're doing how we're doing then? Offline adaptive RT, well, during treatment, we're seeing changes in the anatomy. This is either on the IGRT or on the external contours. If this anatomy change is significant, then we're calling for to rescan the patient. So the patients undergo rescanning, recontouring, replanning, and sometimes re-QA. And that process will repeat whenever there is major changes in the anatomy. So this process is manual and definitely is suboptimal because the time between we make a decision to rescan the patient and the plan is ready is going to take us a few days. And definitely it's very time consuming. What about online? So we got an online adaptive radiotherapy, which can be either based on library of plans or based on daily plan re-optimization. What's the library? And this process is actually automatic and definitely is an optimal solution for the anatomical changes. How we're doing the library of plans? On the sim, we decided that we're gonna be simming the patient multi-scans, depending on the changes in the anatomy, for example. So we're creating, so first we're acquiring multi-scans and we're creating multi-plans, which should be ready before commencing the RT. Depending on the anatomy of the day, I will choose the best plan that fits the anatomy of the day. So we call it the plan of the day. This is definitely a time consuming because we need to scan the patients more than one time and we need to create multi-plans for the patient. And definitely there is this workflow, suboptimal of the workflow because we need to choose the plan, load the plan, so it's very time consuming. This is an example of cervix cancer where you have multi-ITVs that they were generated according to 4 scenarios here. If the bladder is empty to 1/4, if it is 1/4 to 1/2, 1/2 to 3/4, 3/4 to full. So this bladder filling is changing the ITV shape and size. So these 4 plans are created. So 4 scans are acquired, 4 plans are created, and depending on the bladder filling of the day, we're choosing that plan. And this has been an adaptive approach for many years in big centers. What about the daily plan of re-optimization? And this can be either based on MRI or on CBCT. MRI, the available system is the Unity from Elekta. CT-based is one of the most system that's available with the CT-based is the ETHOS. So ETHOS system is an AI-powered advanced solution for delivering adaptive treatments quickly, safely, and accurately. Why ETHOS is an adaptive system? Well, actually, because it has rapid country rotation. You're able to do 4 rounds per minute. This means that you're able to do fast imaging and fast delivery. Improvements in the KV-CBCT image quality, which is due to iterative reconstruction. This means that we're able to do dose calculation on CBCT. AI technology, which gives us the ability to quickly do auto-contouring and also planning, which is a requirement for adaptive. So all these are key features to make ETHOS a suitable system for adaptive radiotherapy. So in the end of 2021, we decided to install the ETHOS system in our department. We were the first in the region to install that system. We had a bunker at that time, which we were using it for brachytherapy. So we switched our brachytherapy system to share it with the CyberKnife, just do the treatments in the afternoon. And we decided to remodel this bunker to fit the ETHOS system. So we added the shielding, the good thing that we got beam stopper on the ETHOS system, so there was a lesser requirements when it comes to the primary shielding, and we expanded the control area. And this is necessary to do adaptive because multi-teams, they're gonna be meeting in this room, especially when there is an adaptive case. So we did the installation in February 2022, and we were able to treat the first patient on May. Just a couple months later, we're able to start the treatments with the ETHOS system. We immediately shifted to adaptive. So we started with adaptive RT. We did not do image guided. And we started with the two cases, rectum and prostate. So what's the workflow of adaptive radiotherapy? It's like any other case in RT. We start with the planning CT. The contours will be transferred to the Eclipse system, then the contours will be created on the Eclipse, and then they will be transferred, the CT and the contours, to the ETHOS platform, where we're able to create a reference plan in ETHOS. On the day of the treatment, we're acquiring a CBCT. That's the first CBCT. AI is helping us in order to do auto-segmentation on the CBCT and the generation of adaptive plan. At the same time, what we do, we load this reference plan on the first CBCT, and this is what we call it, the calculated schedule plan. So we're having adaptive plan and schedule plan, and we'll compare. Is there a major anatomical changes on that day that require to use the adaptive plan or no? If not necessary, we're proceeding with the initial plan, which is. During this process, we're concerned about what happened with the patient. Is the patient moving? Is the anatomy changing internally? So we're acquiring a second CBCT to see. Most of the time, actually, we're seeing just if there is any IGR. This means if there is a movement in the patient. So as if like we're doing a really IGRT, not adaptive. Patient-specific QA, we're doing a Mobius 3D, so independent check on that patient to assure that whatever we get from the plan is deliverable, and then we proceed with treatment. So if we look at the number of patients since the starting of the ETHOS system in mid-May, till now we treated about 250 patients. 183 quarter of the patients were using IGRT, just because they do not require ART, and 1/4 are adaptive radiotherapy. I have to be honest also at the same time, because we are installing a new machine, so one of the machine is down. So we're trying to minimize the ART cases. If we look at the distribution of patients, prostate will constitute the majority, followed by bladder, cervical, colon, uterus, and liver, and others. And once we started, our experience, when we started with the patient adaptive, it seems like we are adapting on a daily basis. So it seems that the pattern that we're seeing major anatomical changes for this patient. So this means once we start with adaptive, we're seeing that on a daily basis, most probably we're gonna select the adaptive plan. It's a team effort. So ETHOS is not just physicists or radiation oncologists or radiation therapists. It's a multidisciplinary approach that involves the radiation oncologists, the physicists, and the radiation therapists. Currently, on the simple cases, physicists attend only the 3 fractions. So if it's a simple case, and mostly it's IGRT, it is led by so we don't, after the 3 fractions, we don't go there, just the RTs. It's led by the RTs. The doctors, the MDs, still they have to sign off. So this means that they have to be present on every session. We are trying to make the RTTs gain more competencies so that to allow them to be delivering an RTT-led service. And this is something that we're working on it in Doha. So this will significantly reduce the need for the clinicians to be present, and definitely will enhance the RTT job satisfaction. If we look very quickly of some of the cases, prostate is an example. This is an example of a prostate, looking at the initial plan plus the SIM-CT. This is if we select the schedule plan. So this is the CBCT of the day plus the initial plan. We're looking that we are underdosing the PTV and overdosing the bladder. If we do ART, we have a good coverage, and definitely we're meeting the requirements for the organ at risk. Looking at the data analysis, we definitely, if we're using ART, we have a better coverage as compared to IGRT. Same thing when it comes to bladder, we're sparing the bladder more when it comes with adaptive radiotherapy. Bladder is another example where the bowel is cropping here. So when we look at the CBCT of the day, we're looking that we are underdosing the PTV here. So we need ART. ART will give you better coverage because just the bowel moved out of the bladder in this case on that day. So depending on the anatomy of the day, we will decide whether we're going to go with IGRT or we're going to go with adaptive radiotherapy. Looking at ETHOS treatment time efficiency, when we started, for example, prostate node and bone mets, we delivered the treatments in 33 minutes. Now we're able to do that in 23 minutes, and this is mainly to these two, which are the contouring, plan generation, plan evaluation, and the QA. And this is where we learned more experience. So we're feeling more comfortable with the system that we're able to do quick contouring, quick planning, evaluation, and the QA. We felt still that there should be another system what we need to do to use it with the ETHOS in order to make sure what's happening between the first CBCT, where all this contouring, planning evaluation is happening, and the delivery. So we thought about, and especially, for example, there were previous talks that talks about 1.5 hours when you're talking about adaptive radiotherapy. So it's important to monitor the patient motion immediately after the CBCT acquisition. So we need a real-time monitoring, and this will be helpful. So we decided that we will install the Align RT from Vision RT on the ETHOS system. It's called the Align RT inboard. So this is an SGRT solution that will be used for setup and monitor the patient during treatment. It's based on 2 sets of cameras. And we installed it this February. And we are using it on our ETHOS system. Just quickly, I will show you what's happening, for example, between the first CBCT, while we're doing the contouring, the plan evaluation, and what happened here, the patient moved. So there is longitudinal movements of the patients. This is why we're doing this planning, which means that we really need to acquire a second CBCT and do the shifts. What we've done in this study, we correlate what IGRT shifts is giving us and what Align RT is giving us. And there is a big correlation between the two. So the translational deltas, which were observed on the Align RT, were exactly the same what we get on the IGRT, on the CBCT matching. So there is an excellent correlation between the inboard Align RT and the CBCT. This give us support that in order to decide whether a second CBCT is needed before delivering the adaptive plan. For example, if SGRT really is monitoring the patient and we're not seeing major shifts using the Align RT, do we really need a second CBCT? Expose the patient to the second CBCT and taking more time. What are the challenges of the ETHOS system? Well, currently for us is a standalone. A staffing limitation, you need expert in the field. We have to develop the staffing model. Some patients are not suitable due to the image quality. I think Variant, they work on that. You have the HyperSight, way better image quality. We have, in the current status, we have limited connectivity with ARIA. The future release of ARIA is better so that the connectivity between ETHOS and ARIA. In summary, ETHOS helped to design patient-specific treatment for us for taking into consideration the anatomical changes of the day. In the examples, we show you how we can manage bladder, prostate, and other cases with adaptive. Our learning process continue with future sites such as abdomen and head and neck. We got some challenges that I share with you, and we're working on research with ETHOS, and there are 2 research funded from Varian from this approach. Thank you, and looking forward to see you all in Doha. We have a Proton Summit in Doha next year. Thank you. Thank you. Sorry for taking long time.